Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 284 of our Pharmacotherapy MCQ series, which majors in peripheral vascular disorders. The first question reads, LEG, a 39-year-old man, presents today with a 4-day history of left-hand pain. He notes that the third digit of his left hand is cold and somewhat blue, especially in the distal area. The other areas of his hand have recovered, but the distal portion of the digit remains cyanotic and numb. He has used acetaminophen and warm water soaks without success. He is a construction worker who uses his hands, quite a bit, in his work. He has a history of gastroesophageal reflux and has no allergies. His social history is significant for smoking 1.5 packs of cigarettes a day for 19 years. On physical examination, his extremities reveal appropriate sensation of the forearm and hand. Some blue areas are noted on the distal portion on the third phalanx, with no other signs and symptoms. When LEG's opposite hand was placed in cold water, several white splotches appeared, and he experienced tingling in this hand as a result of the cold water exposure. He is diagnosed as having Raynaud phenomenon, abbreviated as RP. Does LEG present with primary or secondary Raynaud phenomenon? LEG presents with what is most likely secondary Raynaud phenomenon owing to one of several potential underlying causes. His clinical presentation is classic for Raynaud phenomenon, with vasospasm, pallor, and a cyanotic overtone. The diagnosis is confirmed by the cold water test, which indicates that the vasospastic attack is precipitated by cold exposure. He has a work history that may easily include hand trauma and the use of vibrating machinery, and his age also suggests secondary Raynaud phenomenon. Because of its association with connective tissue disorders, other laboratory tests such as an anti-nuclear antibody and erythrocyte sedimentation rate should be checked. The next question reads, what conservative measures can be taken with LEG to prevent or decrease the painful vasospasm of Raynaud phenomenon? Most patients with either primary or secondary Raynaud phenomenon will respond to conservative management to reduce exposure to triggers such as cold and emotional stress. LEG should be instructed to protect his hands and fingers from exposure by using mittens and insulated wrappers when handling cold drinks, and to protect other parts of his body from cold exposure. He should also try to minimize emotional stress and occupational exposure to vibrating machinery, and avoid medications that can induce vasoconstriction, particularly sympathomimetics, clonidine, serotonin receptor agonists, and ergot preparations. He should be encouraged to stop smoking, which may not affect occurrence of attacks but may decrease their severity and provide an overall positive health benefit. LEG has new onset and relatively mild Raynaud phenomenon. For others who have more severe symptoms and manifestations, especially patients with underlying connective tissue disorders, it is important to immediately and aggressively manage any ulcers that develop on the digits and to be extremely vigilant in detecting infected digits. Rarely, patients who have severe symptoms including ulceration or thrombosis may require surgical intervention such as peripheral sympathectomy, embolectomy, or ulcer debridement. The next question reads, nifedipine extended release 30 mg every day is ordered for LEG. What is the rationale for using a calcium channel blocker in this case? Drugs can be used to treat primary and secondary Raynaud phenomenon if it interferes with the patient's ability to work or perform daily activities or if digital lesions develop. Most proposed treatments for Raynaud phenomenon are variably effective, and they introduce the risk for significant side effects. Drug therapy should always be in addition to non-pharmacologic measures. Dihydropyridine calcium channel blockers decrease calcium ion influx and prevent vascular smooth muscle contraction, especially vascular responses evoked by cold exposure. Nifedipine, a potent peripheral vasodilator, has been studied the most and has become the drug of choice in patients with Raynaud phenomenon not controlled by conservative measures. In primary Raynaud phenomenon, 10 or more episodes per week are common. A meta-analysis showed a decrease of 2.8 to 5 attacks per week and a decrease in severity by 33%. Patients with secondary Raynaud phenomenon experience a similar decrease in attack severity and also achieve a decrease in number of attacks with nifedipine therapy. Because their baseline number of attacks per week often exceeds 20, the relative benefit is not as great as with primary Raynaud phenomenon, averaging approximately a 25% decrease in weekly episodes. Doses of 10 to 30 mg 3 times daily of immediate-release nifedipine are beneficial, although higher doses, if tolerated, may be required for maximal benefit. Most clinicians administer nifedipine as an extended-release formulation to increase convenience and decrease side effects such as dizziness, headache, facial flushing, and peripheral edema, which can occur in up to 50% of patients, and this practice is supported by clinical studies. Although less thoroughly studied than nifedipine, other vasoselective calcium channel blockers, such as amlodipine, felodipine, isradipine, and nisildipine, decrease the frequency and severity of ischemic attacks. Patients who do not benefit from nifedipine likely will not benefit by switching to another calcium channel blocker. Patients who cannot tolerate the side effects of nifedipine, e.g., peripheral edema, and headache, might benefit by switching to another calcium channel blocker. LEG should be warned of the potential side effects with nifedipine therapy, especially dizziness associated with hypotension, and should return in 2 weeks for assessment. A 30 mg daily dose of extended-release nifedipine is a reasonable starting dose. He should be instructed to keep a diary documenting the number of attacks he experiences and details surrounding each attack, such as time course and precipitating factors. In addition to the usual side effects mentioned above, LEG should be aware that his symptoms of gastroesophageal reflux could worsen with nifedipine therapy, which can cause a decreased lower esophageal sphincter pressure. This side effect should be specifically assessed at his follow-up appointment. The next question reads, what other drugs may be tried if LEG cannot tolerate the calcium channel blocker? Other than calcium channel blockers, no proven therapy for Raynaud phenomenon exists. Many agents, however, have been used based on limited data. The alpha-1 adrenergic antagonist Prososin, 1 mg 3 times a day, yielded moderate benefit in 2/3 of patients in 2 small studies. Side effects of Prososin are significant at maximal doses and include dizziness, edema, fatigue, and orthostasis. The longer-acting alpha-1 adrenergic antagonist Prososin was evaluated in one small study, and it improved symptomatology as well as objective measures of blood flow. Insufficient data with this class of drugs exist to routinely recommend their initial use in patients with Raynaud phenomenon. Topical nitrates have been used clinically for several years and newer formulations have recently been studied, but data showing efficacy is limited. Several therapeutic approaches are being vigorously investigated and show promise as future therapies for Raynaud phenomenon. These include the intravenous prostaglandin analogues iloprost and alprostadil, which enhance nitric oxide-mediated vasodilation, endothelin antagonists, such as bosentan, and oral phosphodiesterase inhibitors which also promote vasodilation. A meta-analysis of phosphodiesterase inhibitors for the treatment of secondary Raynaud phenomenon showed a modest decrease in frequency and duration of attacks, although further larger trials are needed. Botulinum toxin A has also been studied. Because of side effects, cost, and administration difficulties, these agents are primarily being studied in the most severe cases of secondary Raynaud phenomenon with digital ulcers or other systemic complications associated with connective tissue diseases. If benefit is proved, however, it will shed light on the pathogenesis of the disorder, and perhaps lead to therapies appropriate for the larger population with Raynaud phenomenon. Statins may have promise in severe cases resulting in digital ulcers secondary to systemic sclerosis, abbreviated as SSC. Pleiotropic effects of atorvastatin 40 mg per day on endothelial function compared with placebo were investigated in 84 secondary to systemic sclerosis patients who fulfilled the American College of Rheumatology criteria for classification of secondary to systemic sclerosis with secondary Raynaud phenomenon despite ongoing vasodilator therapy. The study found a significant decrease in both new and the total number of digital ulcers in the atorvastatin group compared with placebo. The renin-angiotensin system mediators act as vasodilators and have been investigated in several small studies. ACE inhibitors and angiotensin receptor blockers, however, have yielded conflicting results with respect to beneficial effects in patients with Raynaud phenomenon. Small beneficial effects have been realized, specifically with captopril 25 mg 3 times a day and losartan 12.5 to 25 mg per day. However, no benefit has been found with enalapril 20 mg once daily. Fluoxetine, a selective serotonin reuptake inhibitor, was shown in one study to reduce the symptoms of Raynaud phenomenon. It is hypothesized to exert its effect by depleting platelet serotonin, rendering the platelet unable to release a significant amount of the vasoconstrictive serotonin during activation and aggregation. Alternative therapies, such as ginkgo biloba and L-arginine, have also been studied in small trials with positive results. However, larger trials are needed to confirm the findings before these therapies can be recommended. All patients with Raynaud phenomenon should be counseled regarding cold avoidance and other protective measures. A calcium channel blocker, extended-release nifedipine if tolerated, should be initiated if conservative measures are ineffective and titrated to the highest tolerated dose and symptom resolution. Combination therapies have not been investigated, but another agent, such as an alpha-1 adrenergic antagonist, may be considered in addition to the calcium channel blocker if symptom resolution is not satisfactory and side effects permit. The next question reads, HZC, a 62-year-old woman, complains of cramps in her left calf that began last night around 10 p.m. The cramps occurred several times throughout the night and has resolved slowly this morning. These nighttime cramping episodes occur frequently, are very painful, and cause her calf muscle to become knotted, but is not associated with walking. She denies any trauma, fever, or chills, has no other medical problems, and takes no medications. Her physical examination, extended chemistry panel, and thyroid function tests are unremarkable, and her vital signs are stable. HZC works at an elementary school and walks up and down stairs throughout the day. Her physician associates the pain with nocturnal leg cramps. What characteristics differentiate HZC's nocturnal leg cramps from other pain syndromes? Benign nocturnal leg cramps usually occur in the early hours of sleeping. They are asymmetric and primarily affect the calf muscle and small muscles of the foot. These cramps are not associated with exercise, electrolyte or laboratory abnormalities, or medications, although cramping requiring therapy was more likely in the first year of patients being prescribed long-acting beta agonists, thiazide, and potassium-sparing diuretics. For diagnosis and treatment of nocturnal cramps, other causes of muscle cramping, including drug-induced cramps, must be excluded. The onset of cramps at rest is characteristic of ordinary leg cramps and is the primary symptom used for diagnosis. Clinical signs of sodium depletion, hyperthyroidism and hypothyroidism, tetany, and lower motor neuron disease should be evaluated. Laboratory measurements such as standard electrolytes and thyroid function tests can help rule out some of these other conditions. The next question reads, what are the therapeutic objectives in treating HZC? What non-pharmacologic recommendations can be made? The primary treatment goal is to prevent this uncomfortable condition. Given the limited evidence and potential side effects with drug therapy, non-pharmacologic therapy is the preferred initial therapy. Patients are commonly advised to stretch out the afflicted muscle or perform dorsiflexion of the feet throughout the day and before bedtime. Patients are also warned to avoid plantar flexion while sleeping by hanging the feet over the edge of the bed when sleeping on the stomach. Once a cramp occurs, the goal is to relieve the cramp as quickly as possible. Acute therapy consists of dorsiflexion, grasping the toes and pulling them upward in the opposite direction of the cramp. This can be accomplished with the hands, by walking, or by leaning toward a wall while standing 2 feet away from it, maintaining the feet flat on the floor. The next question reads, HZC adopted the recommended stretching practices, and reduced plantar flexion during sleep. She returns 3 months later, and reports a minor decrease in the attack frequency, but not severity. Her sleep is affected 2 to 3 nights per week, and she feels it is affecting her performance as a teacher. She remembers her aunt taking a pill for her leg cramps. Are there any medications that may help relieve her symptoms? A variety of medications have been reported to help treat nocturnal leg cramps, but all have limited, very limited, and inconclusive evidence. Vitamin B12, vitamin E, diphenhydramine, gabapentin, diltiazem, and verapamil have limited effectiveness data, mostly via small single trials or case series. Quinine historically had been the most frequently prescribed medication for nocturnal leg cramps. The FDA, however, has clearly stated quinine should not be used for nocturnal leg cramps because of an unfavorable risk-benefit ratio. Quinine has been used to treat nocturnal leg cramps since the 1940s, when 4 patients having leg cramps experienced marked improvement in symptoms after being treated with quinine. Despite its use, significant controversy exists about its benefit. Only a few small controlled trials have been conducted, with mixed conclusions. A meta-analysis was published in 1998 that included both published and unpublished data addressing the efficacy of quinine in the treatment of leg cramps. Pooled data from 659 patients indicated that quinine, at 200 to 325 mg per day, reduced the severity and average number of cramps experienced in a 4-week period from 17.1 to 13.5. Of note, a recent study that randomly assigned patients to quinine cessation reported no effect on nocturnal leg cramp frequency, e.g., no worsening of symptoms. Synchronism, a syndrome that includes nausea, vomiting, blurred vision, tinnitus, and deafness, is a dose-related side effect of quinine. Tinnitus alone occurs in up to 3% of patients. With overdose, central nervous system manifestations, such as headache, confusion, and delirium, can occur. Self-limiting rashes that resolve with drug discontinuation have been described. The unpredictable and life-threatening side effect of thrombocytopenia was the impetus for the FDA to ban the over-the-counter status of this preparation. Thrombocytopenia has been estimated to occur in up to 1 of 1,000 patients taking quinine. Care should also be taken with the use of quinine because its clearance is decreased in the elderly and several drugs decrease its clearance, such as cimetidine, verapamil, amiodarone, and alkalinizing agents. Quinine can also produce toxic levels of digoxin, phenobarbital, and carbamazepine and is contraindicated in patients with glucose 6-phosphate dehydrogenase deficiency. The last question reads, are there other treatment options for HZC? Electrolyte replacement, e.g., sodium, potassium, calcium, or magnesium, may be indicated if specific deficiencies are noted or if the onset of cramping is associated with a recent initiation or dosage increase of diuretic therapy. Prophylactic use of other pharmacologic agents has been attempted, but their use is mostly anecdotal. Diphenhydramine, riboflavin, carbamazepine, metocarbamol, and phenytoin have been used empirically but no data support their use in nocturnal leg cramps. Vitamin E has been recommended, but one controlled study with 800 international units per day of vitamin E showed no benefit. Verapamil has been shown in an open-label trial of 8 elderly patients to relieve quinine-resistant cramps. A dose of 120 mg of verapamil at bedtime was used, and relief was seen after 6 days of treatment. Similar results were reported from a similar small study using diltiazem. A small study found benefit associated with vitamin B complex administration for nocturnal leg cramps, but no quantification of a decrease in the number of cramps was provided. 2 small crossover studies suggested that chronic magnesium administration is not effective for the treatment of nocturnal leg cramps. Although nocturnal leg cramps are relatively benign, they do cause considerable discomfort. Non-pharmacologic measures should be maximized before drug therapy is contemplated. If drug therapy is warranted, quinine can be tried, but the potential for side effects, especially in the elderly population, is very real. Careful patient selection, patient education, and vigilant monitoring for side effects should all be used to minimize the occurrence and progression of adverse effects from quinine. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 285.